Great, welcome back. Next up is an inside look into how large hospital systems have utilized the HIE to improve patient care and support staff's safety, with a particular focus on how hospital and health systems have responded during the COVID-19 pandemic. So I'm pleased to introduce our panel of physician and health informatics leaders today. With us today, we have Dr. Craig Norquist. He's the Chief Medical Information Officer for HonorHealth here in Phoenix and a practicing emergency physician. He also serves as a clinical assistant professor in informatics at the University of Arizona. Dr. Norquist's interests include improving outcomes and the patient-provider experience through health information technology. Second, we have Dr. Anthony Dunnigan, Vice President and Chief Medical Information Officer for Valleywise Health here in Maricopa County. Dr. Dunnigan is double board certified in clinical informatics and internal medicine and serves as adjunct faculty in biomedical informatics with the University of Arizona, Arizona State University, and Creighton University. And then finally, rounding out our panel is Ryan Sommers, System Director, Health Information Exchange and Interoperability at CommonSpirit Health, formerly Dignity Health. He is responsible for HIE activities across 142 hospitals and 700 care sites in 21 states. Ryan is a certified project management professional and holds a bachelor's of science in information technology. So I will turn the podium over to Dr. Norquist.
All right, well, thank you very much, Christy. So we put together a couple of slides each just so that you guys have an idea kind of how we were using the HIE before the COVID crisis. And then it'll lead us into a conversation about what we used or how we used the HIE to actually further a better use, we think at least, or I think at least, of the HIE to help protect our patients, as Christy mentioned. So if we go to the next slide, just some introductions. HonorHealth, next slide then. Basically, just to give you the background, HonorHealth itself is a 6-hospital system. I can say 6 now because our 6th hospital just opened about 2 weeks ago. It's up off of the 17. You've probably driven past it if you're going north. Multiple specialty surgeries, centers, medical groups. You guys can read that just as well as I can. I hate when people read slides to me. So that's what HonorHealth is. On the other side, we have what we call ICP, or Innovation Care Partners, is our ACO. And up until COVID, that's essentially what we use the HIE for. Our ACO is a very successful organization. As you can see, more than 2,000 physicians, 450 offices, actually has earned a shared savings for 6 years in a row, managing 160,000 patients with multiple different insurance contracts. So if we go to the next slide, just some background on that. This is, part of the reason why our ACO was successful was the integration that they have with the HIE. In that, when our patients who were in our cohort would actually arrive at a different hospital, they would have a real-time ADT message would be sent back to them. Hey, a patient in your panel presented at one of our affiliated hospitals or presented at a neighboring hospital. And then our care managers would reach out and make sure that we were providing them the service that they wanted and try to bring them back and prevent what we call leakage in kind of the population health or ACO mentality. So what happened initially, and if you guys don't mind, I'm just going to give the quick kind of synopsis of what brought us all together in March, was we had a patient at HonorHealth who presented to our ED who had been at a different hospital, told us that they had a COVID test but didn't have the results. And we thought, well, that's a problem. We need to make sure that we know those results, because if that person is positive, we need to get them isolated and put them away from any other patients so they don't get them infected, but then also protect our staff. Fortunately, in that case, it was a neighboring hospital that was on Epic, and so we're able to share through Epic, but that left this tremendous hole where we felt we need to tighten that up, and we put together calls with all of the Valley hospitals, the major Valley hospital players, to try to see how we could do that better. I think we did a phenomenal job of getting that up and running, and it gave a really good example of some of the potential use cases that we could use the HIE for. So with that, I'll pass the buck along and look forward to having more of a conversation.
Awesome. Thanks, Craig. Great speaking to everybody today. You may have heard me speak in the past at these summits. I'm a huge fan of Health Current. I always joke with Melissa, I've known her for 15 years across like 3 lifetimes. So interoperability has been a passion of mine for many years. I'll be at Valleywise Health 6 years tomorrow, actually. So if you go to the next slide, I think I left out the obligatory "Who are we" slide, but you probably know us formerly as Maricopa Integrated Health System, MIHS. For those of you that don't know us, we're the county safety net healthcare system of Maricopa County. So that's been our mission for over 140 years. We are going through a huge reimagination. If you go to carereimagine.org, you can see we're about, I'd say 65% of the way through it. If you've driven past 24th and Roosevelt, you've seen the huge tower going up. So we're going to have an 11-story tower on our current campus, and we're refurbishing our entire ambulatory system as well. So it's a super exciting time. The pandemic slowed us down just a little bit, but not much. So we opened up a new clinic in Levine a few months ago. We have a new clinic in North Phoenix in the Sunny Slope area opening up next month, and a large ambulatory center in Peoria in January. The new tower opens in 2023. So it's super exciting. We've been working very closely with Health Current for a long time. So I just give you a couple pearls here. My boss is our CIO, Kelly Sommers. He sits on the board. I work with the Clinical Advisory Council. And, you know, we're always trying to leverage what Health Current's doing, where they're going with our strategy as well. So we've been certainly a subscriber and a participator for many years. If you go to the next slide, you know, we do that in the ways you heard on the last meeting and some of the things Craig mentioned. We leverage the ADT alerts. Our Sunny Slope clinic currently sits right down the road from John C. Lincoln. So we've got many patients that transverse both our systems. So being able to get those pings is huge. We're both on Epic, so we can do some operability between our systems, but we get ahead of that through the ADT alerts. So we leverage that certainly. Behavioral health is a key part of our business. So getting that information in our system is important. There's of course special rules with that. So, you know, we're all trying to make sense of those. And then we certainly want to get that Health Current information deeper in our Epic EMR, where all the clinical decision support lies. So we're trying to leverage some of the work of other systems now where they've done that. You know, we got insight through the work Craig mentioned with some of the things Ryan had done with Dignity Health and getting that information in their system granularly. So we're trying to do that as well. If you go to the next slide, we'll talk a lot about COVID. And you know, kudos to Craig for pulling this together early on to share what we were doing. You know, it's amazing being in informatics, you kind of get above the political and business fray. And we got right to the heart of it and pulled off some really good stuff that we'll share with you this afternoon. So, you know, this is a screenshot of the COVID alerting, and then we get that document in our EMR that shows the result. I also mentioned the ADT alerts here, and then we're continuing to work. You know, we're seeing the numbers trick up here, so we'll talk more about how that allows us to be proactive when we get that alerting in. I think I have one more slide, which are some current examples of what we're doing here, and I mentioned most of these, and it's really, you know, I can't overestimate having the ability to get those results in. For those patients presenting in the ER or direct admitted, you know, it's not just about saving test results. We're able to put them in the right spot early on. So I know we'll share some more stories about what we did with COVID and what that did for us, but it made a huge difference with what became extremely limited resources, as we all know, in late June and July. I think my last slide is an example of what that alert looks like. So that comes in straight from Health Current. And that's readily available for providers. And I even stole Craig's sort of angry banners that pop up for those positive patients, because they just made such a huge difference. I always, people that work with me, you know, things have to pass the 2 a.m. brand new intern test. And so when that positive result popped in and resulted in an angry flashing thing, people knew that they needed to put that patient in the right place and do something different with them. So. That's us in a nutshell. For an intro, I'm going to pass it to Ryan.
Thank you, Dr. Dunnigan. Can you advance me to the next slide there, please? Thank you. So again, I'm with CommonSpirit Health. We're commonly known as Dignity Health here locally from a branding standpoint, but we recently merged with another big, large health system called Catholic Health Initiatives to form CommonSpirit Health last year in 2019. We've been a Health Current participant since January of 2016. We're doing lots of different things with the Health Information Exchange here in Arizona. We're pushing ADT, we're pushing other HL7B2 messages and CCDs to Health Current so they have that information in their repository. Those are the big hospitals within our Maricopa geography here. We have St. Joe's Hospital Medical Center, we have our Westgate facility, Chandler Regional, Mercy Gilbert, both our Arizona and Mesa General Hospitals, and then Dignity Health Medical Group and all of our clinics here in Arizona as well, along with the urgent cares. We're also doing query-based exchange with Health Current via the eHealth Exchange, which is a large national network. So the point there is with our clinicians and our physicians, we want to keep them within the workflow of our Cerner EMR solution so that we can query out directly to Health Current and bring data back into the workflow of those clinicians on demand. We also have different population health management type of activities that we're doing with Health Current, being able to bring that data in, ingest it into our population health management tools and use it there. And then the ED notifications and COVID alerts is something we're going to talk more about today. If you go to the next slide for me. So the ED alert solution, this is something we worked on with Health Current as a pilot back in early 2019. It was something that we came together with them. What we're trying to figure out is how could we identify high ED utilizers that are visiting other hospital systems across the region. So some of those things, some of those alert thresholds that we put in place working with Health Current were, if a patient were to have 6 or more visits within 180 days, they would notify us that they are an ED high utilizer, or 3 or more visits within 30 days would be a potential notification of an ED readmit, or 3 or more facilities within 90 days to notify us of a traveling patient. So these were some things that we wanted to proactively notify our physicians in the ED that these patients have met these particular alert thresholds so they could treat the patient accordingly. If you go to the next slide for me. This is an example of what it looks like. So in real time, when the patient comes into our ED, there's a real-time ADT alert that goes out to Health Current, and Health Current runs that patient through their algorithm to determine if that patient meets any of those alert thresholds that I just spoke about. And if the patient does, we get a report back that lands in our Cerner solution, and specifically our Cerner Community View solution. And it lands in a what we call a widget for ED information, and it lets us know that we have an ED notification that successfully met that criteria. And you see that there on the left-hand side, how it's organized within the view of our physicians. And then on the right-hand side, there's a sample of a report of what that looks like, what criteria were met, and then some of the visit history that Health Current has on that patient. If you go to the next slide for me. The Health Current COVID-19 alerts were built on that ED alert functionality that we've all been speaking about today. So again, rather than it being an ED high utilizer type of event, the ADTs still go out to Health Current, and they determine if the patient has a COVID test within their platform, and they respond back to us and let us know what the result of that test was, whether it was positive or negative. And again, it's the same technology that was leveraged for the ED alerts, but using a different type of algorithm to determine if a COVID test should be presented back to us in the report that comes from Health Current. So there's some examples there on the screen. Again, the report lands in our ED information widget within Cerner, and then the examples of the reports themselves look similar to what we see on the ED alerts as well. I think that might be all of my slides today. Turn it back to you, Christy.
Yes, perfect. So I actually think we wanted to open it up for sort of a exchange and dialogue between the three of you. I think I will point back to Dr. Norquist first as sort of the initial convener in the Valley, and then with that great story about the patient that you didn't know the test result. So what happened next?
Yeah, so thanks, and I appreciate the kind words, and appreciate actually even being invited to this. This is an incredible experience, so thanks. It was, as Tony mentioned, in informatics, we kind of rise above the competition and some of the other things that seem to kind of slow us down in healthcare. And as soon as that happened, I thought, you know what, let me reach out to people that I know. I reached out to Tony. He helped us get in touch with some other people. We even included people in Yuma and Tucson because people move, right? Regardless of the lockdown, there were people traveling from all over. So what we did is really quickly convened a phone call, actually, with just some of the CMIOs on email, and they said, why don't we leverage what's going on with Health Current? And I think it's, to Ryan's credit, it was some of the stuff that they were doing. They said, we've got this ED alerting system that's going on. We could actually just mimic that to do this. And we thought that that was a great idea. We at HonorHealth initially wanted to do it, instead of present a PDF, we really wanted it to file into our system and have the positive or negative. Unfortunately, as many of us now know, there were so many different tests being run so many different ways and being reported with so many different results that to try to map all of those different tests with the results to all come down to a positive or negative or detected or not detected, it was proving to be way too difficult. So we went ahead then and changed just some of the messaging so that when a test that was either detected or positive or resulted in a way that could be considered positive, the header of that then would file differently than if it was negative or not detected. And then we were able to drive the PDF or that result then to fire our alerting systems. And as Dr. Dunnigan mentioned, those alerting systems pretty much in your face, can't avoid them. Make sure that it was more than, hey, watch out for this person. It was more of a, hey, this person is positive, so you need to make sure you protect yourself and protect anyone who's going to come in touch with them. I felt it was incredible. I mean, I think over the course of about a week and a half to 2 weeks, we'd had almost 4 or 5 phone calls, started to get some of the details worked out. And then it was just a matter of working together to kind of, fine tune it to make sure that it was working fine. And that actually then took us to the place where it was running, it was working fine. There were no concerns about, mislabeled patients or some of the other things that I think maybe have plagued people or had some concerns in the past. Didn't have any of that. We were able to match patient for patient, and I think it worked beautifully.
It really did. And we at Valleywise, we had one of those bellwether moments when your chief medical officer is reaching out to you and goes, hey, we just got this patient in and I didn't see the alert, or I didn't see this come from the HIE. You go, oh, wow, okay, we're hanging our hat on this now, which is good, that's what you want. When we created something like this with these visualizations, you want to be able to hang your hat on it and put faith into it. I became the HIE portal whisperer to an extent. So I'd go in and we'd talk and like, oh, well, you know what? This patient came up from a remote Native American site that's not actually sending data real time. So we came up with a way to enter external COVID data to take care of that. We used this same pipe to funnel into our reporting as well. So we put that much weight on it, and it worked brilliantly. So yeah, just an amazing collaborative effort. The other thing I'll share, and we can talk more about this, but you wait for examples like this. Everything's about a value proposition, right? So the time and effort and human capital you spend on interoperability, it was never more obvious with this particular effort and the importance of it. But think about the multitude of other things. Ryan's work with the the ED high utilizers. Even things like a hemoglobin A1C or a chest X-ray, or you can see the importance of getting those little granular bits in right into the EMR. They participate in decision support, or there's a visualization. So it's now a whole different discussion with my colleagues and the folks in the C-suite that aren't necessarily techie and get kind of the meat and potatoes of interoperability. We're having some interesting conversations now, and we're really looking forward to leveraging this, getting more in, other ways we can interoperate, because the value's never been plainer.
Yeah, I think for me, one of the the big takeaways for me is sometimes it takes unfortunate events or unfortunate scenarios to really drive innovation. It was amazing to me how quickly we mobilized as a group to bring this together and put ideas on the table. How can we combat this particular issue that we're dealing with and come up with a solution quickly, and then really, attribute to Health Current for how quickly they were able to mobilize and spin up a solution that really met the needs of various stakeholders on different EMR systems across the community. They really did a fantastic job in terms of how quickly they were able to mobilize a successful solution for everyone.
Yeah, if I could just add to something that Tony said, I think we, and Ryan as well, we did switch from hey, why are these outside results filing to why aren't these, right? We had patients who were going to some of the urgent cares that weren't participating in the HIE. And it was frustrating to them. That's like, this patient told me they just got swabbed last week and the results are at this urgent care. And so then I found myself actually trying to reach out to urgent cares and asking for them to participate with Health Current so that we could all share in that information, because I felt it was that important. Unfortunately, I wasn't as successful with that as I was with getting a hold of Ryan and Tony, but I'll keep trying, because this is a really great example of why we should be participating. There is a question about, there's a couple of questions. One was, with all the alerts and alert fatigue, and that certainly is a concern, and I hate to say a passion of mine. It's not a passion to fatigue our providers. It's a passion to pull all of that stuff away so that they can actually take care of patients. And if they're going to be alerted by something, it has to be something that's meaningful and something that they could do something with. And we feel strongly, and I think it's hard to disagree with, that a patient who has a infectious disease that's contagious to the extent that COVID is, you can't say that that's not an alert that somebody should see. We actually did contemplate moving it from being that really big interruptive alert to more of a passive alert along the side. And actually we got pushback from some of our docs and our chief medical officers to say, no, we want them to actually have to acknowledge that they've seen that this patient is positive. So it was good. It was unfortunate. As Ryan mentioned, you need the crisis to actually get the burning platform. But how quickly it changed from why is this filing in here to why isn't it filing? And then that kind of springs us into, what other use cases can we use the HIE for, and share information. And I think there's so many different things that we could, and I think that we will start to do, partially based on the relationships that we're able to form through this experience.
Sure. And if I could sort of take that to the next level, what other types of health information functionality do you wish you had in place in March when all this started, or today, in order to better manage this particular pandemic and your hospital's response?
I'll go ahead and start. Obviously it would have been nice if we had that built and we didn't have to go through that couple of week time frame where we had to build it. Would have been nice maybe ahead of time so that we could have lobbied the urgent cares that don't participate, and we could have went to the hospital system that will go unnamed that doesn't participate, that's right here in the Valley. We could have knocked on their door and said, hey, come on, let's all play nice in this sandbox that is Phoenix, and maybe had a little bit more collaboration with those non-participants. It'd be nice to kind of have a better idea of, so that we could load balance, right? So that if HonorHealth is overwhelmed and our southern hospitals are overwhelmed, we can shift internally our patients so that not one hospital is exceeding capacity. It'd have been really nice to be on a collegial kind of platform with all of the other players in town to say, especially as Northern Arizona was getting decimated and overwhelmed, where we could have more of an agreed upon sharing system, which ultimately did happen. But it would have been nice to kind of know that was something that we'd all thought about beforehand.
Yeah, as we all know, these patients, you had to get in the door and get admitted. You had to be pretty darn sick. We had people being cared for at home. My internal medicine colleagues were like, we're going to do this guy at home on 4 liters of oxygen? Like, yep. It's going to, with the monitoring, it was a whole new day for care coordination and home monitoring. And by and large, we pulled that off very successfully. But to Craig's point, I think actually Dr. Rucker said something that just really struck a chord with me this morning. And I could hear him, as an ED doc in his voice. He's got interoperability to the point where he knows that the patient came from the ED. But what happened the 2 or 3 chess moves before that? And so you imagine that patient's story, having that in your hands as you're trying to care for these incredibly complicated people with comorbidities and medications. And it's just the value of having that full story to the extent you can has never been more obvious than when we were in our fairly dire situation with these ultra complicated patients and having to make decisions about resources pretty quickly. What's the right place for them in the hospital? Is there somewhere else they should be rather than my hospital? What resources do I need to surround them with? So, again, that value proposition piece.
Ryan, if you don't mind, I'm just going to piggyback off of something Tony mentioned, and I think it also would have been nice, and I think we ended up playing nicer. Nothing erodes confidence in our patients anymore than if they show up at a different hospital and the doc is saying they did what, right? If a patient was discharged from Valleywise on 4 liters of oxygen with a pulse oximeter and shows up at one of our EDs, if we don't know that they've agreed to do that and manage their patients that way, and they show up and we're like, oh my God, that's malpractice, we're not doing anybody any favors, right? We all need to come to agree and understand that we're all in this crisis together. And that is becoming this kind of emergent standard of care where, okay, yeah, you weren't sick enough to make it into our already crowded hospital. So what is it that we can do for you today that is outside of what we would have done last year in the same time, without having that look of shock or horror on your face as a provider when a patient tells you, oh yeah, I've got, bilateral pneumonias with COVID and my SATs are 88%, but they sent me home on oxygen with this little thing on my finger. It's like, yeah, that's what we do as well. And, let's help you get better and get through this, as opposed to, oh my God, I can't believe they did that. So, unfortunately, it took this horrible crisis to get us to kind of understand that we're all needing to do those same things. And I think that we'll continue to work together and make sure that if one of us is doing that we understand why, and we can lend at least the caring eyes and caring support.
Yeah, selfishly speaking, at CommonSpirit Health, we participate in approximately 20 community or statewide HIEs across the country. And Health Current is really the one and only HIE that we participate with where we have this type of technology in place, whether it's the ED alerts or the COVID alerts. Would love to see some sharing of information across HIEs. I believe that probably happens today, where Health Current potentially share how they've implemented this type of technology with some of the other community and regional HIEs that are similar to what they do across the country, so that we could leverage that more broadly nationwide. So I think there's a way to take this at a larger scale across the country.
So if it's time to maybe pivot away from COVID for some of the other ideas.
There we go. Yes.
And one of the things that we're working on, and we've already had a meeting with Health Current, would be around the social determinants of health. Those factors that have more to do with somebody's health outcomes than what we do as providers. And I've been kind of beating this drum in our organization. It's like, we can't start asking our providers to ask difficult questions of patients until we have something to give them when they give us an answer we weren't anticipating. You don't want to ask a patient if they don't have the financial means to feed their children and then say, oh, wow, that's too bad. So how about your car? Does your car run well? No, you need to address that. And we're all in this weird position now where we're being told social determinants are important, ask these questions. And then we're all kind of looking around for what are our resources, and we're lending, or we're having to look for these aggregators to kind of help with matching resources to needs. And I think, taking that further, if it's uncomfortable for docs at HonorHealth to ask those questions, it's uncomfortable for docs at Valleywise and at Banner and at Dignity, or CommonSpirit, wherever that patient may be. And it isn't so much just to protect them from uncomfortable questions, but if we have a resource that Valleywise didn't have, and that patient was asked that but didn't have a match for that resource, why wouldn't we try to match that resource to that patient? For instance, we work with Desert Mission Food Bank, and if the resources that Tony had for a patient or Valleywise had for a patient maybe didn't quite work out for them, if they showed up with us at HonorHealth, we would love to know that they actually have that need, and that we can actually, try to match them with our resource. And what we're finding, and what you guys are probably all aware of, those are the kind of things that actually really help our patients, right? I mean, your diabetic patient who actually is getting some fresh fruit and vegetables is going to have a much easier time controlling their A1C than if they're going to 7-Eleven and having to buy, whatever the cheapest food is that's calorie dense and nutrient poor. And that's what we need to do more of, is try to get those kind of things so that we can share not just some of the difficult questions, some of those answers, and share those resources so that our patients are doing better and making our providers' lives a little bit easier.
That's funny. I'm working with one of our informatics fellows, and he had never seen that zip code map of the life expectancies in Maricopa County. And if you haven't seen it, the easiest way I can think to get to it is to Google VCU, Virginia Commonwealth University, Google VCU life expectancy map, and you can pull up Maricopa County, and it's just striking. So, so thanks for mentioning SDOH, because it's, I know we're all passionate about it. I'm super glad Health Current's in that game. It's actually changed our decision a little bit about what direction to go in. So we're sort of going to, make sure we leverage whatever comes out of Health Current. To have that data in our system and interoperate it, absolutely huge. If you think about the loop closure piece, it's a little daunting. I think we all get it now, right? Your genetic code's more important, or your zip code's more important than your genetic code. We've bought into that. But the screening, how we codify that social determinant, how we identify a resource and link to it, and then that last step where you make sure that the patient did go to the food bank, or maybe they went one time and they were intimidated or something happened. It's a complicated loop. And if we can share even part of that loop with each other, I agree 100% with you. That is huge. That's an investment I think all of us will make. Well, the indirect benefits are obvious, from a business strategy point of view.
I agree. I would echo everything Dr. Norquist and Dr. Dunnigan just shared. It was good. Thank you.
Yeah,
So,
some other maybe less obvious use case, or maybe they are obvious use cases. I mean, to piggyback off of the COVID result example would be, at some of the Epic user group, we're on an Epic EMR, Epic user group meetings. They talk about, here are some initiatives to save millions, and they're actually kind of simple if you think about it. It's those tests that a patient only needs to have done one time in their life. But yet, if we can't find it in the EHR as an ED doc or an internal medicine doc, we're going to order it again and again until we, have that answer right in front of us. For instance, some of our coagulopathy, somebody who forms blood clots more frequently, we order this panel of these genetic tests that need to be done one time in their life. Some of them might need to be done more than once. And then there's some of these other tests too that we tend to order a little bit more frequently than we need to. And those are those kind of things too, that if somebody had a factor V Leiden test at Valleywise or at CommonSpirit, why isn't that available to me when they come into the ED and they have a blood clot? And my hematologist says, hey, we need to do a coagulopathy workup on them. I'm like, I've already got it done. And we just need to figure out which medication to put them on and then let them go home. And then that kind of piggybacks into the next phase, which maybe there's some questions there, would be, why can't we share some of the pharmacogenetic information? If somebody is getting a test panel to find out which medications are more effective for them, be it pain medications or a platelet inhibitor medication after a cardiac stent, or even antidepressant medications, there are panels that can be done, and they're actually tested and done here in the Valley at Norquist. Unfortunately, those results are sent back to our organizations as PDFs, and essentially they make our computer decision support useless because it's a PDF and those results don't file in there. So if we can work closer with them and have those results available, then we can all put in our computer systems that logic so that, this patient will do well on Plavix, which is pennies on the dollar compared to, the latest, greatest antiplatelet inhibitor after a stent. And we could save not just our own organization money, but we could save that patient money, right? Because ultimately they're going to have to reach into their pocket and pay. And then we save the entire system money. And that's really what we need to be looking at, is not how can we outcompete somebody on efficiencies, but how can we make the system more affordable and more intelligent for everybody? So there's a lot of potential there. I think that we can work together.
Yeah, Craig, those are great examples. I think about, anything that comes under the umbrella of healthcare maintenance, right? Cervical cancer screening, colon cancer screening, mammography, immunizations, the appropriate tests or medications for someone with diabetes or high blood pressure or cardiovascular disease. Anything that falls into that broad bucket of a care gap. There's a direct quality component. There's a direct value-based care component. Some of the panelists on the last session spoke very eloquently about their role in value-based care. I think interoperability has a huge part of that. Our patients are, our folks are going to all of our EDs, right? And sometimes they're there because they live, they're right down the street and they have an acute thing. So to the extent we can share that, they're getting the right tests done. Those are even more, I'd say, low-hanging fruit examples than the two really good ones you brought up.
Yeah, speaking a little bit from a technology standpoint, something I think we can continue to work with Health Current on, because Health Current over the years has so many contributing sources, and they've done a great job of onboarding so much across Arizona. We have some opportunities to work on data provenance. So when we're querying Health Current, we're getting back an aggregate CCD. We're trying to parse that CCD out, map that appropriately for our clinicians so that we put it in the right place. So the labs go to the labs, the procedures go to the procedures, and really making sure that we're identifying data provenance is something that is on our radar, for something to continue to work with Health Current on how we can make sure we do a good job of that.
I was just going to say, thank God Ryan's here to use, sophisticated words like data provenance, but because I just want it to work, and we rely on people like him and people like Health Current. And honestly, it was an excellent experience. And, had it not gone so well, I don't know that we'd be saying, such glowing things, and nor would we be even willing to consider some of these other opportunities. And I think these other opportunities are exactly what we need to do. And I honestly do think that it's not going to be very long before we really start to see some cost savings and some patient benefit that's being driven from conversations with colleagues.
So there's a question in the chat, thoughts on leveraging the HIE for all the reporting requirements put forth both federally and state mandated, and how to leverage the HIE to report on behalf of hospitals so your staff can spend time taking care of patients. Thoughts on that?
I don't think any of us are going to say, no, we want to do that. So to whatever extent that it can be, some of that lift can be shared by others. And as Dr. Dunnigan mentioned, the idea that somebody is loyal to an organization is appealing, I think, to our, C-suite of hospitals and such, and the marketing people, and they do everything to have that stickiness. The reality is, people are going to go where it's convenient and where people treat them nice, right? I mean, if you're treated well someplace in their ED, and your doctor who might be in another organization says, hey, I need you to go get this procedure done because it's a screening, they're going to go somewhere else that they have a comfort level with. We would like to know that that's happening so that we can actually then try to win them back from a competition and capitalist kind of notion. But there's no reason we shouldn't be able to acknowledge that they close that care gap and that reporting mandate that's there. And those are the kind of things that I think we need to kind of, come out from under the shroud and kind of look around and say, hey, how can we do this better? Because there is a lot of waste and there is a lot of inconvenience, mostly to our patients, but then also to our providers who are having to care for them. So if we can figure out how to do the reporting, or how you would do the reporting for us, I'd say, sure, please do.
Yeah, I couldn't agree more. I know I see Melissa mentioned in the chat, just the COVID reporting, which was, we probably pulled 4 or 5 people off and focused them full time on COVID reporting. So that, to have Health Current be a body that could do that. Sometimes it was, we've got a data set, oh, now they want this other piece, or another piece of our system capacity. If you think about the HIE, it's such a robust data set. And maybe the technical part is just changing the pipe a little bit versus the data flowing in. It's daunting. And I know we're still really geared up on reporting, and you know, the number, I know we all have this angst, right? And so we're certainly in a much better shape than we were in March, April for reporting. But yeah, absolutely. Whatever we can leverage with Health Current on reporting is a win. Even if it's, you know, giving somebody 2 hours a week back, that's huge.
Yeah, I echo everything Dr. Norquist, Dr. Dunnigan said on reporting, and anything we can do to leverage the HIE to help streamline or take the burden off of our reporting responsibilities to the state. It really feels like a no-brainer. There can be some complications with an organization like ours where we are in 20 different states. It might depend on the type of reporting that we're talking about. Because we're in so many different states, we try to sometimes standardize internally how we do those types of things versus having 20 different approaches to how we're going to report that from state to state. But generally speaking, it seems like an absolute something that should be looked into and see if there's something we can do there.
Sure, and just so that you're aware, we actually have a couple specific projects coming up. One, electronic case reporting with the Arizona Department of Health Services, and then a grant that Health Current was awarded like 10 days ago from the ONC to support hospital bed reporting via the HIE for COVID. So really focusing in on those reducing administrative burden areas. I wondered if you might talk a little bit about what's next on the horizon for your hospital in terms of other applications like population health and data analytics, some of those more elegant applications of HIE within the hospital system.
Go ahead, Tony, you can jump in.
Yeah, I'll just continue my thought on the role of data and the HIE and value-based care. That's probably, as we get back to some sort of remnant of normal, I guess we're here for a while. We've re-engaged and refocused on population health, and particularly the business layer of that's really our value-based care programs. So I mentioned the care gaps and the ability to plug in if the patient's had a mammogram here and I can bring that in granularly and it satisfies the healthcare maintenance reminders. There's a visual component to that. It gets in the right place in our reporting and it becomes real physical data in our EMR. That's kind of the magic at the end of the rainbow. So I know we're working on more of these things that'll end up being granular. It's always great if I can go see it. Maybe I have to log in, go see it, and then I can manually put it somewhere. And we're doing that. But to get that even a level deeper across that broad bucket of care gaps that's probably one of our biggest things as we get back to kind of a strategic mindset. The other thing, we all spun up telehealth, right, and virtual care. So I think about the role of the HIE in that as well. I don't have the patient in front of me now. I've got the information I have in my EMR. What else is out there that can supplant and support that virtual experience? So I think that's going to be something we'll be talking about over the next year or so.
Yeah, at CommonSpirit, we are, I mentioned we have federated data exchange in place with Health Current. So we send real-time queries outbound to Health Current and we get an aggregate CCD back that has the patient's entire patient history from Health Current. And we do that thousands of times a day. So we do that anytime a patient has an encounter. If they show up at one of our EDs, we fire off a real-time query to Health Current and we get that data back. If we know a patient has an appointment the next day, we send overnight queries to Health Current for upcoming appointments. And we get all that data back. We do a really good job of bringing that data back for providing care for the patient and for care coordination activities. But we have other solutions that we use for data and analytics where we're not currently today doing a great job of bringing that data and bringing it in and doing analytics on it. So that is on our roadmap this particular year for us to work on. And we've got a project we're just now starting to kick off to work through those types of things as well. So lots of opportunity there to continue to leverage the HIE for other use cases within our organization.
So one thing we were, I was trying to work together with a couple of ED docs from Valleywise to try to get an idea of the impact of COVID on emergency department volume. And I think we all can look now and say, wow, we're down. We're down almost as much as 50% at times, still down about 20%. But how much more powerful would that have been had we had everybody who's on Health Current and a kind of a dashboard where you could see something's going on where, you know, everybody in the East Valley isn't going in, but while the West Valley is overwhelmed, not just so much for COVID, but, you know, the next time we have a Super Bowl or the Phoenix Open, if we get back to those kind of crazy events, that we can start to do a little bit better job of load balancing and leverage, you know, the HIE, so that we can have an idea of, all right, we maybe could start to ask patients to drive a little bit further so that we can offload those facilities that are being impacted by whatever that event is that's going on. Kind of similar to what Boston did, you know, during the marathon bombing, although they did it with just an incredible amount of field support with people, you know, shuttling ambulances to all of the different trauma centers and rotating. They did a really good job with that. Not that I don't have confidence that we could do that here, but they had the benefit of having, you know, a single or a couple of different EMS providers where we've got multiple different organizations on that front as well. And so to leverage that information that might be housed in one facility would be the place. As I mentioned too, we're very moving very much forward in our social determinant work. And so, you know, try to leverage what other people are doing on that so that we could share some of that information, that knowledge. And then just maybe it is a pet project of mine would be the pharmacogenomic stuff, because I just see so much sense in that you know, once we can put in place the reason why this panel is important to get, because it's kind of an expensive panel that doesn't get covered. But if somebody was to get that, why do they have to carry around a piece of paper or something in their wallet to let that provider know, who may not actually, you know, have the time or the ability to put together what those results mean for what medications? And you know, and then on the other side, we don't see the utility in making somebody build all of those rules for, if your CYP2D6 is positive, then you need to have this medication, not that medication. That all exists, and we would build it if we had enough people with the test results. So we're kind of in this chicken and egg, you know, situation where we don't know what to do, because we see some value in it, but we don't have enough people with that. So I see, you know, maybe leveraging a state HIE to kind of help us jumpstart those kind of projects, so we can already have that built-in patient population.
Okay, there is another question in the chat from the audience. Is there a need for HIE enhancements to address the dual threat of the flu season and COVID?
Well, we're all nervous about that. Go get your flu shot. I just got mine. I don't know if that refers to the alerting piece and bringing, you know, flu data in like we do COVID data. It's not, you know, because we have an effective vaccine, and the PPE and where you put those patients isn't quite as dire. But I'd probably say, you know, alongside other key information that relates to morbidity or things that are going to affect care of those patients, particularly COVID patients, we certainly want that. I know we're designing protocols, and I would include RSV in that too. So flu, RSV, COVID. They had a mild season in the Southern Hemisphere. I think we're all hoping for that. You know, clearly social distancing and things like that are going to make an impact. But you know, my short answer would be yes. That's all important data that we want at our fingertips.
So the alerting technology that's set up, you know, it's algorithm and rules based. So, you know, all the things Dr. Dunnigan just mentioned, if you could tie together known patient comorbidities with these illnesses and trigger alerts based off that, maybe it may be information that we don't otherwise have in our own home EMR. That could very well be a great use case going forward, and some additional ways that we could build and expand on the technology that's out there today.
Yeah, and I would add to that too, just, you know, the possibility of knowing if somebody has had their flu shot or not, right? Right now, not everybody, you know, knows what shot. You ask somebody, did you get your shot? And they're like, I think I got the pneumonia shot and maybe this other shot. You know, if we could actually have that information right in front of us, then it's that one less thing that the doc needs to do for the care gap. But then also, you know, all right, what as a provider do I need to be concerned about if you come in and you have a fever and confused and have low oxygen levels, right? If you've already had your flu shot, or if you've already been positive for the flu and we had that information available, that's going to make me think differently than if none of that has been obtained by that patient. It might help us on, redundant flu testing over and over and over if somebody's kind of, moving around the valley due to their job or occupation or whatever that might be. But yeah, I agree with Tony that, we're anxious about the upcoming flu COVID wave that might happen. And we're kind of also hoping that we'll see the same thing the Southern Hemisphere did, where it didn't happen because of masking and social distancing, but that could all change overnight.
So we have just a few minutes left. If there's any other questions from the audience, just feel free to add them to the chat. I did want to follow up with kind of closing the loop back again on the COVID piece. So what have you, as hospital leaders here in Arizona, what have you really learned during the COVID response so far that would be useful in addressing any other type of future pandemic or any type of disaster event?
So I'll go first because I don't want these guys to steal my answers. No, don't be afraid to fail, and don't wait for perfect before you implement something. We put out these alerts and people are like, wow, that's kind of ugly. And it's like, all right, help me make it better. But I just needed to get something in front of you. And then we started to make them smarter so that there was actions tied to them. Before the pandemic, I think a lot of us were afraid to put something out that wasn't perfect because it would get attacked and then you'd have to pull it off. And you would only get that one chance to have your providers use something. I think more than anything, this proved that's not the case. You need to get something that's good enough, but also then be willing to change it on an almost continual basis as you're finding little imperfections with it. And then never assume that your colleagues or competitors across town aren't struggling with the same things as you're struggling, and share everything that you can, because it isn't so much your facility, your ego, but it's that life of that patient that you're really going to save by helping somebody else out. And as Tony mentioned, our alerts, we had them pretty quickly, and we just shared them with him as soon as he saw them. He's like, hey, I like those, can I have them? It's like, sure. They're not proprietary, and both of us being on Epic, we were more than willing to share. So those are some of the big takeaways that we learned.
Yeah, I mean, there's a huge silver lining in this thing. Think outside the box thinking. One of the reasons I enjoy working with the College of Health Solutions, these kids come up with these ideas, and I'm like, I don't have a reason why that wouldn't work. It's going to be difficult to implement, and the rules as they exist business-wise may not make sense to do that, but it's a great idea. And so we came up with some of these just to keep care going. I stood up a very lightweight video chat platform. We ended up using it for virtual family visitations and virtual rounding, and we found all sorts of things you could do with it out of pure necessity. So, while it's stressful being in a period of pure necessity, I love the outside the box thinking. And Craig's absolutely right. Don't be afraid to fail. Those of us that have studied Lean Six Sigma, the PDSA cycle, part of that is things don't go the way you thought they would. Well, you take that data, you put it back in, and you try again, and you iterate it. So, those are two huge silver linings through this thing.
Yeah, I really like what Dr. Norquist and Dr. Dunnigan stated. Don't let perfect be the enemy of good. We had something that was pretty good. We thought it would work, and we put it out there, and we'll continue to iterate on it and make it better. And the other big lesson learned for me or takeaway for me is something I stated before. It's when we have these moments where there's something really critical going on or a really unfortunate scenario, it's really incredible how quickly people can come together, throw a bunch of ideas on the table, think about what might work, and build it and make it work within a matter of days or weeks that this was stood up. So but that was really the big takeaway for me, is just how quickly we were able to mobilize and get something together for this.
And I just have to add a quick shout out to Health Current, because they almost, to me, are like an innovation think tank in a way. Some of the things around opioids, medication utilization, it's a great group. They're always like, what can we do? What value can we give to you with this data? And we need more of that, because whatever the next thing coming is, it's going to be about, that sort of innovation. So that's one of the reasons I enjoy being part of this
Okay, we have just moments left. If there's any final thoughts for the audience on hospital collaboration during the pandemic.
I would just add, if anybody knows organizations that aren't participating, help us out by trying to get them to join in and share data. And it is a sharing of data. It's not just giving. It's you're going to get something in return. And if you don't see the value in it, you know, I'll put myself out there as a resource that I can help try to explain why it's important for them to participate so they can get something in return. I'd imagine Ryan and Tony would be right there with me. So let's reach out to some of the people who have resisted with your help, and then, you know, feel free to use me as a resource, and we'll do what we can to try to make all of Arizona kind of healthier through the work by all of us and by Health Current. Wow, that sounded kind of cheesy. Sorry.
That's great.
Yeah.
I love ending on a love fest note. So that's great. So I'd like to thank you all, Dr. Dunnigan, Dr. Norquist, Ryan, for participating in this panel, actually for bringing forth the idea in the first place and being willing to have a collaboration discussion. I think the audience learned a lot from some of the questions in the chat that I've seen. And so I just appreciate your ongoing support and participation with Health Current.
Thank you for the opportunity.
Thanks.
That was it.